I've been tasked with discussing evidence-based models of reperfusion for myocardial infarction, and I must admit I changed my talk a little bit this morning after your guest speakers last night. I think the discussion about equitable healthcare delivery and cardiac delivery in Sri Lanka were very positive, and I thought I'd perhaps just provide some insight into some of the issues that we face in Australia as well. I'm going to talk about the AHA guidelines briefly, and we'll go through the importance of timing. And we're going to talk about some of the systems and pathways for early recognition, and we'll contrast and compare primary PCI versus thrombolysis, and then perhaps talk about an encompassing reperfusion strategy based on geography. If we look at present guidelines for reperfusion and myocardial infarction, we know that they're divided into the mode of presentation, whether you present to a primary PCI capable hospital or not. And if you do present to a primary PCI hospital, it's pretty straightforward. If you can get a procedure within 90 minutes from first medical contact, you should go ahead and do so, be it primary PCI. If, however, you don't present to a hospital with a PCI capability, it becomes a little bit more difficult. And we talk about some newer definitions like door in, door out, which means coming in the front door and going out the back door in an ambulance to the next hospital. But in essence, if you're able to deliver primary PCI from first medical contact to balloon inflation in less than 120 minutes, it's still recommended that you proceed along that pathway. And if you don't, and if there are no obvious contraindications to thrombolysis, then the suggestion is that you thrombolyze a patient within 30 minutes of medical presentation. And then the discussion comes down to what do you do at that stage? Do you transfer them urgently if they fail to reperfuse, which seems obvious? And secondly, do you transfer them routinely within a significantly short time frame for systematic PCI? And a lot of this data is based on what we know about myocardial infarction and what we know about the ischemic wavefront of necrosis that occurs when you have coronary occlusion. And that is to say, if you achieve reperfusion within 30 minutes, it's to the major degree reversible. And after that, there is a window of opportunity within perhaps 3 hours where there is a significant salvageable myocardium, and after that it starts to diminish and the curve starts to flatten out. And if we look at the second graph, when we look at the mortality reduction, you can see that the money is where it's the earliest. And so you need to aim to do reperfusion as early as possible by whatever means possible within the first 3 hours. And after that, it becomes less relevant for large mortality reduction. There is some reduction and there's some salvageable myocardium, but it tends to drop off. And at this stage, I think it's fairly clear that mechanical interventions like primary PCI are optimal. And this comes down to the pathophysiology of clot formation and platelet-rich thrombi earlier and fibrin linkages later, less amenable to thrombolysis. So the Hunter New England area is a district within New South Wales, Australia, and it covers 130,000 square kilometres, and we service 900,000 people. And we have one cath lab that does primary PCI. And so that in itself will tell you some of the challenges that we face regarding optimal reperfusion in our area. And it's notable that we have a couple of large tertiary hospitals. We have a variety of smaller community hospitals, and then we have clinics as well. And 25% of our hospitals don't have 24/7 coverage. 2 of our hospitals have none and are staffed by nurses. And 25% of our hospitals have general practitioners on call to come into the emergency department when required. The cardiac stream is a structure within the area which is designed to ensure equitable healthcare delivery throughout the area, regardless of geography. And that sounds like a very noble cause, and sometimes it's difficult to achieve. I'm one of the leaders, and my co-leader is Mr. Lindsay Savage, who's a clinical nurse consultant and has spent many years with reperfusion strategies. It's essentially an advisory board that looks at implementation and maintenance of area-wide protocols which pertain to cardiology. And the next sentence sounds like a bit of diplomatic talk, and it kind of is. It says, we prioritize initiatives to the area executive based on clinical need after evaluating available evidence whilst being mindful of resources. And that means we fight a lot to get the money we need where it's best allocated. And that's the reality of what we need to do. And I was I thought it was very positive that your health administrator yesterday spoke so positively about resource allocation. Now, our stream is a combination of clinicians, nurses, allied healthcare professionals, and administrators, all representing hospitals within the area. So when I look at evaluating available reperfusion data, I find it quite difficult. And it's challenging because if you look at the literature, there's a spectrum of presentations that relate to time, geographical location, and the healthcare system. The therapies, the primary therapies and the adjunctive therapies are evolving with time. The endpoints differ, the timing differs, and the definitions differ. And with all that in mind, we need to assimilate the data and think about a reasonable strategy. How do we create a system of early recognition and triage which will best identify the patients? And in New South Wales and in Hunter, New England, we are a large user of the LifeNet cardiac care system. And this is a LifePak monitor as a defibrillator with a built-in ECG, which has an automatic diagnostic algorithm called the Glasgow algorithm, which presents you with an ECG-generated diagnosis of ischemia. It's got a high sensitivity and thus does not miss many infarctions. We arrange for these to be available in ambulances, in emergency departments, including clinics where there are only nurses and general practitioners who have the ability to do an ECG where there's a suggestion of an acute coronary syndrome, and it is then transmitted to a central centre via email and via fax, and then disseminated to an address list of cardiologists who are on call, and some of which who are not on call. I've received a few last night, and that's a good fail-safe mechanism. But that allows us to phone a number on the ECG and have a direct conversation with an ambulance paramedic, a nurse, or a general practitioner about a presentation, and triage appropriately and direct them towards an appropriate treatment modality. So in our area, we look at a variety of different reperfusion strategies, and including the Prehospital Assessment for Primary Angioplasty, which we call PAPA. We look at rapid inter-hospital transfer, prehospital thrombolysis, a Pharmaco-invasive Approach, and nurse-administered thrombolysis. So what we really need to do is, given our geography, is have an integrated pharmaco-invasive strategy. Because at the end of the day, it's not about the modality, it's about the timing and the outcome. And we talk about a hub and spoke model where your hub of the wheel is your quaternary centre with a primary PCI facility, and the spokes are a variety of community hospitals and clinics which feed inwards. And I'll come to this diagram a little bit later, but in cases where we can't provide timely PCI, we provide thrombolysis in a timely manner, and then we have strategies to obtain reperfusion mechanically if required within certain time frames based on the evidence. So there's little doubt that thrombolysis is important and is being utilised in a very high percentage of myocardial infarcts around the world, and it's validated. If we look at ISIS-2, over 17,000 patients in a very well-constructed, randomised, double-blind, placebo-controlled study looking at streptokinase and aspirin and a combination of both, with a cumulative endpoint of vascular death and an unequivocal benefit with streptokinase and aspirin. There's some caveats with thrombolysis. There's a reinfarction and a reischemia risk, and it's honestly about 25 to 30%. It just is. It's time dependent, and it's more time dependent than primary PCI, and we've got good data to show that. And one of the Achilles heel really is intracranial hemorrhage. There are some There's some debate now about the dose of thrombolysis, and we'll go into that a little bit later in some areas. Now, there's a very good time, Borsman in his Lancet article looked at the relationship of time between short-term mortality with thrombolysis in over 50,000 patients in a combination of 22 trials. And it's quite convincing that earlier is better with thrombolysis. So 26 lives saved per 1,000 within 3 hours, as opposed to 65 lives saved within 1 hour. And that's really quite remarkable. There's been adjunctive therapy which has added to the benefit of fibrinolysis. And for example, if we look at the addition of clopidogrel, there are 2 trials, the Clarity TIMI 28 and the Comet trial, both added clopidogrel to a regimen which included aspirin and fibrinolysis and improved outcomes, including infarct patency and vascular outcomes in MACE. The addition of additional therapies like enoxaparin as opposed to unfractionated heparin has also showed a significant benefit in outcome, albeit at the risk of a slight increased risk of bleeding. And that's been adopted as a Class 1A recommendation. So as an interventional cardiologist, I'm going to talk about this for sure. And so primary angioplasty versus fibrinolysis, I think the debate's over regarding what's better, but it's about how you deliver it. So if you can, the consensus is that primary PCI is the preferred approach to reperfusion if you deliver it in an expert center in a timely fashion. And those are 2 really important things to talk about. Cindy Grimes did a meta-analysis of over 23 trials and showed that primary PCI quite significantly reduced recurrent ischemia, infarction, stroke, early death, and combined endpoints as opposed to thrombolysis. When we talk about where you get your primary PCI done, is that an important factor? And the answer is it really is. And the National Registry for Myocardial Infarction in the US looked at over 27,000 patients, and this goes back over 10 years now, and looked at institutional volume related to mortality. And there's no doubt, if your center is doing more primary PCI, you're going to get better outcomes. And people have recognized this and have incorporated it into their guidelines. And I must say, my personal feeling is that a lot of the minimum volumes are still a bit too low, but nonetheless, we have to work along those lines. What about the timing? And these trials that we have, they're fantastic, and the door-to-balloon times are wonderful, but how does the real world actually compare to all of this? Now this is old data. It's from the NRMI registry as well, but it looked at door-to-balloon times, and not mentioned on this slide is that less than 4% of people had a door-to-balloon time of less than 90 minutes. And what you do see here is the time is muscle concept of your mortality increasing as your door-to-balloon time increases as well. And so this is an important concept, and how do we conquer it? Well, prehospital assessment is really a way to achieve timely reperfusion. Now, if we're talking about a door-to-balloon time of 90 minutes being optimal, we know that every second and every minute is precious. And if we break it down further, we can achieve more by working in different aspects. And so we break it down into the rule of 30s. We talk about the ambulance, the emergency department, and the cath lab. And each of them, we give them 30 minutes, and we work on narrowing it down by a few minutes. You'll have a significant improvement in time. With pre-hospital activation, there's certain things that we're able to now bypass in ideal circumstances. So early recognition, you bypass a non-PCI hospital, so you don't have to worry about transfer. You bypass the emergency department and reduce the time spent there, and you activate your cath lab earlier, and thus everyone gets up early and is sitting around waiting for the patient in an ideal world. Now, I present this little graph with permission from the New South Wales Ambulance Service, and I've de-identified the Sydney Hospital because it's not really relevant, but what it does show is that a door-to-balloon time of 90 minutes prior to activation, which is pretty good, has actually been improved to 67 minutes, looking at both the ambulance activation and those presenting to the emergency department, and those actually pre-activated went down to 41. So that's a significant time saving. Now, my colleague Peter Hansen and his colleagues at Royal North Shore were involved in the initial pilot process, which was called ITAMI. Everything has a different acronym, but it was basically the same. And they published this data in 2007, and they looked at pre-hospital activation and field triage, and they showed pretty convincingly that the door-to-balloon times, or the symptom-to-balloon times, differed from 154 to 249, and that translated into a mortality benefit. And that's pretty impressive. Now, not everybody presents to a tertiary hospital or phones the ambulance. Some people just drive to the hospital, and they don't choose where they go, they just arrive. And what happens when they arrive in a hospital which doesn't necessarily have a PCI facility? So there's been a fair amount of data that looks at transfer between hospital for primary PCI as opposed to thrombolysis. And the meta-analysis by Cindy Grimes' group really did look at this sub-analysis as well and showed that despite time delays, there still was a significant benefit in myocardial infarction and recurrent ischemia and stroke in those patients transferred for primary PCI. And there are a few other trials that have really added to that. One of the issues that is always raised is what is the risk of transferring a patient with myocardial infarction? Do you need to stay and stabilize them? And in fact, the risk is actually pretty low. So the risk is about 0.5%. The risk of a ventricular arrhythmia is about 1.4%. And in one small trial, they showed an incidence of a high degree AV block in 2% of cases. So what are the other system approaches we have apart from primary PCI? And here with geography and large travel distances, pre-hospital thrombolysis becomes perhaps an attractive proposition. And this is not a new concept. This concept back in the 90s, the GREAT trial in the UK, looked at thrombolysis in the home as opposed to in the emergency department. And I guess the trial was somewhat confounded by significant travel delays due to remoteness in getting patients to an emergency department. So there was really a 2-hour time difference. And that translated in a significant reduction in mortality. And that really opened the eyes of many people to early triage and delivery. If we look at pre-hospital fibrinolysis within an integrated strategy of reperfusion, I think the Vienna STEMI registry is a good example. And this looked at applying appropriate guidelines of reperfusion to a healthcare system within Vienna. And not only pre-hospital thrombolysis, but appropriate and early recognition and treatment regardless of modality. And it showed a couple of things. It showed that, first of all, the proportion of patients actually being treated, the proportion of patients who weren't treated dropped from 34% down to 13%. The in-hospital mortality dropped to 9.5 from 16%. And when you looked at the analysis based on time to treatment, those treated within the first 2 to 3 hours with predominantly pre-hospital thrombolysis was similar in mortality benefit to primary PCI. In the Hunter, New England area, we instituted a pilot program of pre-hospital thrombolysis. It was not well received by many people, and it initially was a pilot program in very rural areas where there was no hope of access to primary PCI. Ambulances went into these areas. They were equipped with the ECG that I described previously, and that ECG was then emailed to a cardiologist who then gave an interpretation and going through a checklist with a paramedic delivered thrombolysis. And that was a very successful program with significant reduction in time to reperfusion. And based on that, pre-hospital thrombolysis was extended in our area in a more widespread way. And I present this data with acknowledgement of my colleagues Peter Fletcher, Andrew Boyle, Paul Stewart and Lindsay Savage, and in the knowledge that they're working this towards publication. And I'm grateful for them allowing me to use it today. But from our perspective, we said in the Hunter, New England area, if from first medical contact you were an early presenter, and at the time it took you to get to a cath lab was greater than 60 minutes, then we should consider pre-hospital thrombolysis, with the caveats that there should be no contraindications to it. And if you were less than 60 minutes away, you should have primary angioplasty. And that was with the knowledge that the door-to-balloon time once you hit the hospital was probably going to be about 20 minutes as well. And that's a pretty conservative approach as opposed to the 120 minutes of the guidelines, and we accepted that, and we were working more within the 90 minutes. But we acknowledged that if people who presented later, that was a different paradigm and they'd be treated differently, and we would be having different considerations, perhaps in the elderly and those at risk of thrombolysis. Nonetheless, this was over 2008 to 2012 that was really first started, and what we really saw is that there was a significant improvement. If you look at time to treatment, it was 35 minutes with thrombolysis and 90 minutes as a door-to-balloon time with similar mortality. The nurse-administered thrombolysis is something that occurs in rural areas where we don't actually have a doctor available. It's a strategy that has been first started in the Hunter, New England area and now is being adopted around Australia. And we utilize the Glasgow algorithm, and we have a checklist of confirmation. We've only treated 10 patients with nurse-initiated thrombolysis, but the average time from first medical contact to needle was 14 minutes. And it's pretty impressive. It's impressive because we're empowering people who are very protocol-driven. We have maintained a link to physician interpretation as opposed to many other areas that don't. We feel it's a very important fail-safe maneuver. It does not take a lot of time in our estimation, probably a few more minutes, and it gives us and our allied healthcare staff a remarkable comfort in knowing that they've got a cardiologist at the end of the line. That may change in the next few months in areas where, due to remoteness, there's no mobile phone reception, and that is being considered at the moment. So, what about the pharmaco-invasive approach? Now, the pharmaco-invasive approach is becoming more attractive based on trial data in areas where we can't provide primary PCI. There are a few trials, and we'll talk about them. Just briefly, rescue angioplasty, we've got to talk about it because we talk about thrombolysis a lot, and we've got to know that the caveat is that 30% of those people won't reperfuse. And if they don't reperfuse, what do you do? And really, it comes down to rescue angioplasty. And as an interventionalist, we don't particularly like doing it. It's somewhat messy to do. But nonetheless, if we look at the data and we look at the meta-analysis, it's better than doing nothing. And certainly, it reduces reinfarction, it reduces heart failure, and it reduces mortality as a combined endpoint at the expense of increased bleeding and stroke. And what's notable in most of the meta-analyses that we look at, there is no benefit with repeat thrombolysis. And that's an important point to take away. So looking at our pharmaco-invasive approach, what about facilitated PCI? Take everyone after thrombolysis straight to the cath lab and let's have a go. Well, the answer is no. If you do it too early, there's no benefit, there's increased mortality, there's increased bleeding. There are a variety of postulates as to why. The earlier trials that looked at it were suboptimal in their adjunctive therapy. They didn't use stents, but even if you're looking at later trials like the ASCENT-4 trial, there is harm in less than 3 hours. But what we do know is that you get a maximal mortality benefit within the first 2 to 3 hours. So thrombolize patients and then consider a window of opportunity where you can do systematic PCI. And that has been shown in a variety of trials, which would suggest that it's safe to have a strategy, I would say, from 3 hours to 24 hours of considering coronary angiography with a view to intervention after fibrinolysis. We've taken the approach in our centre that we routinely transfer every patient who's received thrombolysis directly to our hospital, and we assess them at that stage and either perform a rescue angioplasty on the merits of their clinical presentation or perform a coronary angiogram within 24 hours. And that's a practicality approach as to when you open a cath lab. So in conclusion, look, systems of early infarct recognition and triage significantly improve timely access to reperfusion therapy. Primary PCI is the preferred therapy when performed in a timely fashion by an expert operator in a high-volume centre. But a pharmaco-invasive strategy of rapid pre-hospital or hospital thrombolysis followed by systematic PCI within 24 hours, I think is a practical alternative in many communities. I'd just like to acknowledge my colleagues in Newcastle and New South Wales Ambulance. Thank you very much.